that brings us on to our final speaker. Dan Horner, consultant in emergency and critical care medicine at Salford Royal. Different aspect of patient blood management, again, about appropriate triggers this time in our acutely unwell patients. Over to you, Dan.
Thanks, Shane, in particular for that thinly veiled threat about sticking to time. I shall do my best, and I shall scoot through some of the slides to make sure we all get opportunity to get away. Okay, so thanks everyone for the opportunity to come and speak. So I work as an intensivist and a major trauma consultant at a neurosciences centre in the Northwest. And we use your services a great deal, don't we, in critical care and in the ED. I think the data would suggest that somewhere between 30 to 50% of critical care patients will have a transfusion during hospitalisation. And I think we've got the dubious honour in the ED of probably being joint top with theatres of the major hemorrhage protocol activation numbers. So we use a lot of products, and I wanted to talk really today about common indications, about some of the clinical thought process, how trauma differs in particular, and some of the recent research in this space that's led to a change in thinking. If we start with trauma, then around 25% of the deaths in trauma are directly related to uncontrolled bleeding still. And we've done a lot of work on this in terms of arresting of hemorrhage and realigning sort of advanced trauma life support principles to focus more on uncontrolled bleeding and how to mitigate that as early as possible. But we still see a lot of it. We still see a lot of fatality, unfortunately. And when we look at those deaths in particular, around 25% have a degree of trauma-induced coagulopathy, which we still don't understand brilliantly, I think it's reasonable to say. But we've done a lot of work in identifying it and trying to mitigate it and looking at the things that might help. And some of that has led to different strategies in how we treat. This is a nice primer from Nature that kind of describes the detail of trauma-induced coagulopathy, and particularly the challenges of treatment based on the fact it's multifactorial. It's really dependent on your baseline state, your phase of illness, the acute response that your body launches to trauma, and the interventions provided. And you can see here there's very mixed phenotypes. So some of our trauma patients will be very coagulopathic, some will be a bit more prothrombotic, and of course this does change over time, so not necessarily diagnosable through conventional coagulation tests as we would for other inpatient groups. And it's hard to think about that kind of infographic at 2 a.m. in the morning when someone is bleeding to death in front of you or is critically unstable. So we tend not to think about transfusion triggers in trauma particularly. And we tend to go with a more simple strategy, which is the red wine strategy. And I don't know if anyone has heard this analogy. I've heard it as orange juice and other different fluids, but people will now say, if you take a glass of red wine and you pour half of it onto the road, and then you measure the concentration of what's in the wine in your glass, it's likely to be the same as it was originally. And that's quite a good way of thinking in trauma, because really what we want to do is we don't want to spend time delaying and wasting and measuring. We want to replace what that patient has lost to try and restore some physiological stability and try and promote clot production and stability so that we don't get concurrent bleeding and we don't kind of spiral into ongoing exsanguination. And this kind of thinking has informed research over the last 20 years, which has informed changes in practice, which has informed NICE guidance. And since 2016, we've had NICE guidance for major trauma suggesting a one-to-one strategy for blood product replacement using RBCs and thawed or fresh frozen plasma. And that is working very well. It's good to say, I suppose. So this is data from the Royal London Trauma System, and they've looked at their deaths from massive hemorrhage over a 6-year period in this paper, and report slightly more than a 20% mortality reduction with the use of conventional transfusion strategies. So, that's great, isn't it? We should all be congratulated, you guys in particular, for making these products accessible to major trauma patients, giving us timely opportunity to correct coagulopathy, and giving us an opportunity to kind of change the paradigm of transfusion in trauma. Certainly as a clinician, access to major hemorrhage packs and access to radiology have been the two huge game changers in trauma, which have really saved lives. But there's always room to improve, and there's always potential to think about what more we could do. And there's been loads of work in this space, which is really interesting. So I thought I'd share some of that with you. This is data from the recent iTactic trial that looked at whether we could be more individualized and we could tailor our blood product resuscitation strategies. And this used viscohemostatic elastic assay testing, so TEG, or in this case, I think it was a ROTEM-based blood analysis of patients who were suspected to have massive hemorrhage arriving to the major trauma system in London. And this was a randomized control trial, very difficult to do. You know, it's a complex patient group. They're not frequent attenders, and there's lots of clinical things to do immediately when someone like this arrives. So very impressive of this team to randomize just under 400 patients to a strategy that used conventional coagulation tests and clinical gestalt to decide on transfusion requirements compared to a VHA-guided, ROTEM-guided system. And unfortunately, these authors didn't really show any benefit from early TEGs in trauma. So if you look at the bottom of the forest plot and the overall patient group, you can see there's a trend towards some improvement with VHA testing, but the confidence intervals overlaps the line of no difference. So no statistically significant result here to suggest that early VHA testing can be mandated or that it will change practice. But some really interesting hypotheses arising from this work, particularly with regards to traumatic brain injury. And you can see just halfway up the table here on the forest plot, the TBI patients seem to do loads better with a VHA guided strategy, and interesting to think about why that was and how we might take it forwards. Should we give more platelets in our transfusion strategy? So, you know, NICE doesn't necessarily recommend routine platelet replacement in the context of trauma, but some people like to talk about it and like to consider it early, thinking it will promote primary hemostasis. This is, I suppose, one of the informative trials, the proper trial published in JAMA in 2015, looking at a one-to-one-to-one strategy for replacement in around 500 major trauma patients. That one-to-one-to-one was 6 units of RBCs to 6 units of FFP to one pool, one adult therapeutic dose of platelets. And that was one strategy. The other strategy was 1-to-1-to-2. So for every 12 units of blood, you would give 6 units of FFP and one pool of platelets. And again, no statistically significant result here. So no difference in mortality or morbidity between those two groups. And you can see that through the Kaplan-Meier curve here in the overlapping confidence intervals. But a suggestion of some benefit with early platelet use. And I know in North America, they're still quite big fans and advocates of early platelets within their massive transfusion policies for trauma. I think in the UK, we haven't shifted through NICE guidance yet, and most of us would be a bit more judicious about it, really. What about additional factor concentrates? So this is a really interesting randomized control trial published this year in over 4,000 patients, looking at additional prothrombin complex concentrate infusion on top of a major hemorrhage protocol activation and one-to-one strategy. These authors, unfortunately, with the addition of PCC, didn't show any improvements in reduction of blood products required within the trauma cohort, and didn't show any additional benefit for mortality or morbidity, but did show an increase in VTE events. So an 11% absolute risk increase in the amount of thrombotic episodes for patients receiving the 4-factor PCC on top of major hemorrhage protocol activation. So an interesting result, you know, not one I think the authors were expecting, but one that does make us, I suppose, frame this concept of hemostatic resuscitation a bit more as a curve, you know, and a thought process that, yes, we need to resuscitate aggressively and early and on a broad spectrum for our major trauma patients who are trying to die in front of us. But there is a point and there is a cusp at which point we will push people into a thrombogenic state, and we need to be cognizant of that. Fibrinogen concentrates had a lot of press, as has cryoprecipitate recently. Here's a list of feasibility trials, some of which say it is feasible to deliver early cryo to these patients, some of which say it's not, some of which say it's probably quicker to give fibrinogen concentrate if you're going to give anything, none of which have any kind of practical use at present in terms of guiding our fibrinogen replacement strategies in trauma, because all these trials are quite small. They're between 50 to 100 patients, and really they're looking at the mechanics of delivering fibrinogen replacement early in the trauma journey rather than looking at clinical benefit. But many of you, I'm sure, supported the CRYSTAT-2 trial. I'll mention that in a sec, but that's a pragmatic trial looking at early delivery of cryoprecipitate for trauma patients, and we're hoping to get some results from that published soon. Finally, in trauma, early plasma has got a bit of attention, and this is a trial looking at pre-hospital plasma therapy in just under 500 patients who were attended by an aeromedical service in the US. And this trial is very positive about the use of early plasma therapy, but it's quite hard to put it into a UK context now, given that a lot of our air ambulance services will carry both blood and plasma already, or we'll be shifting to deliver the SWIFT trial, which I'll mention shortly. What's particularly noticeable from this data, though, is again the work on traumatic brain injury and the suggestion that early delivery of VHA guided strategies or early factor replacement strategies to those patients with emerging traumatic brain injury might have a real benefit in terms of clinical progress. Now, these are all hypothesis generating results within the trial, so I'm not sure people will be activating your labs or will be asking predominantly for this, but certainly something to think about for the research space going forward. And what have we got on the horizon? CRASH 4, I mean, we just had a great lecture about tranexamic acid. CRASH 4 is an ongoing randomized trial looking at the benefits of early intramuscular tranexamic acid administration for patients over the age of 50 with mild to moderate traumatic brain injury, to see if taking tranexamic acid nearer to the kind of time of incident will be helpful, and seeing if it will have a benefit in those mild to moderate head injury patients as well as the more severe ones. CRYSTAT-2 was a large randomized controlled trial of around 1,000 patients in the UK trauma system who had the major hemorrhage protocol activated early in their patient journey, and it randomized patients to receive additional cryoprecipitate on top of the major hemorrhage protocol. We've had an investigator meeting about that. I'm afraid I can't share any details yet, but the manuscript is in draft, and I think it's being presented next week at the Critical Care Reviews Conference. There'll be results out in the public sphere soon on this, and that will be very interesting. And then we're recruiting, and I'm sure many of you are, to SWIFT, which is this concept of whole blood as compared to component therapy for acute resuscitation in trauma. And that's very much filling up their glass of red wine, isn't it? We're just giving people back exactly what we think they've lost at the roadside, and looking to see whether that has any incremental benefit for mortality and morbidity. Okay, that's trauma. Racing through other critical care transfusion triggers. Then I suppose it's prudent to start with red blood cells. And if trauma has been over the last 10 years, more is more, and we need to keep doing things early in the patient journey to reduce the risk of trauma-induced coagulopathy and this kind of downstream risk of mortality. For other critical care patients, I think we have very much gone towards less is more. And we've been looking over and over at restrictive transfusion triggers and how we can reduce giving blood component therapy to our patients on the units, and how we can reduce the risk of transfusion reactions. And in bold here is a list of randomized controlled trial cohorts now where a restrictive transfusion threshold for critical care patients would seem to be superior, or certainly not inferior, to a liberal threshold for guiding transfusions. And this work is summarised pretty nicely in a Cochrane review published a couple of years ago that looked at over 21,000 patients and summarised that in the vast majority of cases, a restrictive transfusion threshold of somewhere between 70 to 80 seems to outperform liberal transfusion thresholds, and also reduces blood product requirements by around 40%. So really compelling data there, and data that most of us have adopted. There are some caveats to that, though, and this is work looking at those patients with chronic cardiovascular disease or unstable angina who hit critical care and have transfusion requirements. And unfortunately, the kind of systematic review data there would say that the risk of MACE, of major adverse cardiac events such as myocardial infarction, acute coronary syndrome, or cardiac arrest, does tend to see some degree of increase when you think about restrictive transfusion strategies. in these patients. And is that clinically relevant? I think it probably is. So we did some work with colleagues in Edinburgh, published in ICM there as bottom reference in the tropical study, where we measured troponin, high sensitivity troponin on all patients arriving to the critical care unit, and we correlated that data with on downstream estimates of morbidity and mortality. And sure enough, if you look at high sensitivity troponin in critical care admissions, it's raised in about 70% of patients, and you see biochemical evidence of myocardial infarction in somewhere between 25 to 50%. So that's a rise and or fall of troponin correlating with dynamic ECG changes. And we know that those patients who suffer either type 1 or type 2 myocardial infarctions go on to have an increase in 28-day mortality. So when you see forest plots like this suggesting that you're going to increase the rates of MACE by favouring restrictive transfusion thresholds in these patients, and we know that that's going to correlate with mortality increases, you can see why some intensivists are still very anxious about the idea of restricting transfusion therapies in those patients with a degree of cardiovascular disease. We also don't really understand how restrictive transfusion thresholds impact some neuroscience conditions. So there's ongoing work in TBI and subarachnoid hemorrhage that I'll talk about in a second. But some of this work has led to nice guidance again, which I think has already been mentioned today, talking about transfusion thresholds and targets. And we see a very clear recommendation here for restrictive thresholds outside of the setting of acute hemorrhage or acute coronary syndrome and chronic cardiovascular disease. What does the research landscape look like? Well, we've just finished recruiting to HeMotion, which is an international trial of restrictive transfusion thresholds in traumatic brain injury. So I think over 800 patients randomized across Canada, North America, and the UK and Europe. So that's just in follow-up. We'll see publication results from that hopefully sometime this year. And then Sahara is a similar concept, but looking at subarachnoid hemorrhage patients, so restrictive versus liberal transfusion thresholds in that group. And I think the neurosurgical population is increasingly buying into the idea that we might do more harm by giving lots and lots of transfusions and increasing that circulatory volume and pushing patients into pulmonary edema and chest type complications. But we need to see some data, I think, before there's a shift in practice. So if that's red cells, what about other types of coagulopathy and transfusion triggers along the lines of FFP requirements, platelet requirements, cryoprecipitate requirements in a critical care setting? This is where it gets really interesting, I think, because we've previously had very objective numbers around when we would ask for FFP replacement in critical care, especially if we're pursuing low or high bleeding risk interventions such as invasive intravascular devices, intercostal drains, intracranial pressure bolts, those kind of things. But we're increasingly coming across this concept of rebalanced hemostasis, which is really being pioneered by thrombosis and hemostasis clinicians and those working in the field of acute liver injury and chronic liver disease. And this is an interesting slide. I took it from the Scientific Standardization Committee guidance from the International Society of Thrombosis and Hemostasis for patients with cirrhotic liver disease. And they provide a nice kind of interim summary of how rebalanced hemostasis is this concept of the fact that your conventional tests of coagulation might be slightly deranged, but your body compensates for that over time, often by increased production of procoagulant proteins that we don't necessarily measure. So actually the patients have a reasonable balance here. And so when we try and correct the INR of 1.6, what we actually do is often push them more towards a procoagulant state. And this is engineered such thinking now that most people would recommend that we don't routinely even assess PT or INR, and we certainly don't correct it prior to low risk bleeding procedures such like line placement. So that's really interesting moving forwards. Interesting to see where that gets to and how it is adopted across the region. Some data here on platelet transfusions. So this is a summary of recommendations from the European Society of Intensive Care Medicine. Talk about when we should consider platelet transfusions in critical care. And again, the bar is really low now for this, the bar is being increased such that it's actually quite high. So, this group would say if your platelets are over 50, you don't really need to replace them, whatever you're doing. If your platelets are between 10 to 50, it's up to you, think about it, but you probably don't need to replace them until they drop below 30. And some recommendations there around plasma, as you can see on the screen. But this will change and is fluid. So this is a study published again this year, looking at platelet transfusion thresholds for patients undergoing low bleeding risk procedures, published in the New England Journal of Medicine. And unfortunately, this is a study showing that the bleeding risk did increase by 7%, significant bleeding risk, grade 2 to 4 catheter bleeding, when you were randomized to a no transfusion platelet threshold. So I suppose the point I'm making with this slide is that this isn't sealed yet. This kind of less is more strategy with regard to platelet transfusion. I think it probably is quite patient specific and procedure specific at the moment. But we've got more stuff coming. So ICNARC, the Intensive Care Audit and Research Centre for the UK, is leveraging a study on threshold for platelets, which looks at different thresholds of 10 to 50 and randomizes depending on the procedure type, depending on the threshold. And we'll see more data on that. And then we're seeing a lot more data on thromboprophylaxis in certain situations like traumatic brain injury and others, which I will add to the tapestry of information. Final slides, because I just want to leave a few minutes for questions before midday and closing remarks. I suppose the biggest point for me to make is that we've had huge change over the last 10 to 20 years in the way that we resuscitate from a perspective of major hemorrhage and in major trauma. And we've seen really good evidence of the clinical benefits that can provide, and when we should, I suppose, theoretically ignore transfusion triggers, look at the patient in front of us and think about replacing and filling up that glass of red wine. And in that acute setting, more has become more up to a point, and now we're really in that territory of deciding how much is too much, and can we potentially rationalize who we are delivering these enhanced interventions to. But in the next sort of 1 to 7 to 28 days of that critically ill patient's journey, then we've got more evidence to suggest that less is more, and we can be restrictive with our red cell transfusions, with our FFP transfusions, and our correction of coagulopathy, with our platelet transfusions particularly, and potentially some others. And I hope that's of benefit to all of us. I shall stop there. Thank you very much for your time. Happy to take any questions briefly.
Wonderful. Thank you so much, Dan. Really, again, interesting topic. While others are thinking about their questions, can I ask maybe a loaded question? In terms of trauma, you're talking about triggers and sort of the BSH guidelines say, maintain the hemoglobin over 80, say, but we know that maybe the samples that we're taking may not be truly accurate if someone's acutely bleeding. Are laboratory tests going to be a thing of the past? Are we wasting our time sending these tests and waiting for an answer which may not even be that accurate?
Yeah, good question. It is quite loaded, isn't it? I think we would all struggle not to send conventional coagulation tests at the point of arrival. I think a lot of us are moving towards slightly more dynamic measures of coagulopathy. So we have access to TEG success, our trust, and we like it, and we use it for the complicated patients. Where I think the big practice change has been, and probably is still developing, is that kind of sequential assessment of coagulopathy and bleeding. And I think when you've got a trauma patient who is a transient responder to your major hemorrhage protocol, and you're moving them to theatre, and then you're moving them to ICU, and your blood pressure's all over the place, and your blood gas analysis is difficult, and you always feel like you're playing catch up, I think most of us then are just stopping sending conventional coagulation tests routinely, because we just don't really see the benefit in knowing what things were like 45 minutes ago when it's so dynamic. But I think none of us would want to throw them out of the water completely. And when you get that stability that you're aiming for, then it's really important, isn't it, to kind of get an accurate measure and a conventional measure that everyone understands, so that you can then think a little bit more about rationalizing what you do. And often they're a really good way of you starting to then take your foot off the gas and say, well, hang on, the fibrinogen's good here. The PT and the APTT are not too bad. The hemoglobin's 85. Let's hold fire for a bit. Maybe this is the time for us to give some fluid, having avoided giving it for the last 2 hours. So I think it's dynamic, the change, I suppose, is how I would summarise. And I think we will be sending less, but I certainly don't think they're a waste of time.
Good answer. Good answer. Brendan wants to know, is point of care the answer? So are you guided by, you mentioned the gases and
Yeah.
your TEG or ROTEM, is that what mostly helps you in the acute phase?
I think it's really helpful, and I think it's dynamic. Access and cost effectiveness certainly a big caveat. So there isn't really any national guidance, and there aren't really any hard studies, that have concrete evidence suggesting VHA guided strategies are clinically effective or cost effective. So it's quite a hard business case to write, really, that we need more TEG machines everywhere. We tend to save hours for after we've used the first major hemorrhage pack. So, I would never want it to delay acute resuscitation, but after we've given that 4 of blood and that 4 of FFP, and we're still slightly uncertain about what's happening, then I find it to be a really helpful measure of what should we prioritise next. But we're sending our samples to theatre from resus, and so there's a delay with that. Other centres have them as real point of care devices in their emergency room. And they like them, and one of the results from my tactic was, okay, the findings aren't very positive, but none of us want to stop using these machines, and so we're going to carry on using them and see what happens. So I think there'll be more data over the coming years, and I think there'll be more usage, and we'll have to see how that impacts transfusion. But point of care is not absolute point of care, is it? TEG success, it's still taking a sample, still finding someone who knows how to use the machine, processing it, logging on to the TEG success manager, looking at how it develops over time, and in the real thick of things, that's quite hard to do. So I prefer to do it after an hour or two when you've given some degree of volume and you've got some stability and you can take time to look at it.
I was going to do one final question before we close, and that was going back to one of the slides that you had, because I noticed it as well, about not giving iron and not giving EPO and not giving iron and EPO together. So the question is, why is it contraindicated in critically unwell adults?
Yeah, I was interested to see that when I was preparing for this talk. We don't give much iron on our critical care unit. I've never really thought about why. And when I saw this, I was quite interested to see the recommendations against. I'd highlight that, it's a conditional recommendation with low certainty evidence. So I think, the ESICM acknowledge some of the challenges in the research space. I think some of it comes from an avoidance of dilutional coagulopathy, and a lot of the time we're trying to restrict the volume that we give patients on a critical care unit. But I think it's interesting, and I know other centres do like iron transfusions. They're quite proactive about them. I think it needs a bit of demystification, if I'm honest, in acute care. So I think it needs someone who's quite passionate about it to drive it and be very proactive, because the current guidance, errs on the side of negativity.
Yeah. So as you say, there's no sweet spot that we've identified. We know we have to, look to optimize our patients and provide, iron support for those that are iron deficient. But as you said, there's no real guidance as to when and how to do that.